Thank you, Mark. It's a pleasure for me to be here at Loyola. I've had the pleasure of being here a couple times before and am delighted to be back. Let me get right into this topic. When people think about religion and medicine, most people, I think, first think about what has come to be called the faith-health connection. And that is the question of how religion and spirituality, however measured, have an impact on or are related to or associated with health outcomes, however measured. But I want us to focus on a little bit different question, which is, what does religious faith have to do with the practice of medicine? What does it have to do with the work of clinicians like many of you? Let's consider a case as we walk through this. LC is a 56-year-old carpenter who presents to his primary care physician, Dr. Stern, after his wife notices that his eyes are yellow. It turns out he's also been losing weight and feeling fatigued for a few months. Dr. Stern sends the patient for appropriate tests, including ERCP, which reveal cancer in the head of the pancreas with liver metastases. The patient's bile duct is stented during the ERCP. The patient returns to the office, and Dr. Stern sits down to talk to him about his diagnosis and what to do next. Now, in a case like this, what does religious faith have to do with how Dr. Stern responds to LC? No one believes now, if they ever did, that this encounter between Dr. Stern and LC can be reduced to a generic patient with a generic illness, meaning a generic clinician with access to universally valid scientific evidence. Indeed, over the past generation, a series of patient-centered movements have emphasized that patients bring to their experiences of illness particular histories, cultures, values, and yes, religions. Think of these movements: patient-centered medicine, integrative medicine, holistic medicine, culturally competent medicine, narrative medicine, and spirituality in medicine. Each of these, in their own ways, embraces the influence of patients' particular histories, cultures, religions on their medical decisions. But even this patient-centered medicine and the parallel emphasis on patient autonomy tend to preserve an idealized vision of the clinician as more or less a generic, predictable representative of the one biomedical profession, answerable to data and to a unitary standard, and rigorously steeled against the meddlesome influence of their own so-called personal values. Now, that may be a little bit of a caricature of this typical view, but I think this conventional narrative in which patients are culturally and religiously diverse and interesting, and in which clinicians are dependably evidence-based and neutral regarding religion and personal values, turns out to be false. So in what remains, I will take stock of what we know about the influence of physicians' religious faith on their clinical practices. It turns out that doctors are more or less as religious as patients in general, and that their religious faith matters for their practices. I'm going to then try to make sense of this connection between faith and clinical practice, to suggest why we should not be surprised to find that religious faith influences medicine so much. And finally, propose how we might move forward in light of the connections between religion and medicine toward faithful practices of medicine. So I'm going to propose that as what I think is a reasonable ideal that we might encourage in one another and in our students, is that specifically with respect to religious believers, that they would be encouraged to think about and understand and work out faithful practices of medicine. Okay. Over the past 9 years, my colleagues and I have conducted six national surveys studying more than 9,000 U.S. physicians to describe religion-associated variations in physicians' clinical practices and clinically relevant attitudes across an array of clinical domains. We have so far published more than 40 papers from these studies, with many more in process. And if anyone is interested in them, you can download them from our website, this Program on Medicine and Religion website. But in the interest of time, I'm going to just give a small snapshot of 3 core findings that emerge from that research. The first finding is that physicians are not so irreligious. For a long time, conventional wisdom held that physicians were, on average, much less religious than their patients. And this conventional wisdom was due in part to studies of scientists who tend to be much less religious than the general population, and to broader studies in which those with more education and those with higher incomes tend to be less religious. But we found that physicians, despite being scientists of a sort, certainly having a lot of scientific training, and despite having significantly above average incomes and above average education, are more or less as religious as members of the general population. 88% of physicians endorse some religious affiliation, as compared to 87% of the population. 46% of physicians attend religious services twice a month or more often, compared to 40% of the U.S. population. 76% of physicians believe in God, compared to 83% of the U.S. population. And 56% of physicians say they are very or moderately religious, compared to 62% of the U.S. population. Quite similar. Now, physicians are somewhat less likely to agree with the statement, "I try hard to carry my religious beliefs over into all my other dealings in life." 58% versus 73% of the U.S. population. Physicians are more likely to consider themselves spiritual but not religious. In our study, about 20% of physicians describe themselves that way, compared to about 9% of the U.S. population. And physicians are more likely to be from religions that are underrepresented in the U.S. population. Here's a table that illustrates that. As you can see, physicians relative to the population are a bit less likely to be Protestants or Catholics, significantly more likely to be Jewish, Hindu, Muslim, Orthodox Christian, Mormon, and Buddhist. So that's the first finding. The physicians are not so irreligious, and that they are somewhat more religiously diverse, at least as concerns their religious affiliation. The second finding is that physicians are conscious, self-conscious, of religion impacting their practice of medicine. 55% of physicians agree with the statement, "My religious beliefs influence my practice of medicine." 69% agree with the statement, "For me, the practice of medicine is a calling." Now, we did not ask whether they thought of that as a religious calling, but we did find that religious physicians were particularly likely to identify their work as a calling. Now, with these data in mind, let's return to Dr. Stern and to LC. Let's say that Dr. Stern is Jewish, raised conservative, but for the past few years she and her husband have participated in an Orthodox synagogue. Not only is she observant, but she's been studying Jewish medical ethics by reading books and participating in a monthly study group. She would agree with the statement that medicine is a calling, although she might prefer to call it a sacred obligation. Now, given that, how might we think Dr. Stern's religious faith would matter, if at all, for her care of LC? Before getting into that further, let me talk about the third finding from our research. And that is that religion-associated variations in physicians' clinical practices are prevalent in many clinical domains. I'm going to show you some data from these 4. The domain of spirituality in the clinical encounter, that of how doctors respond to basic mental health concerns, how they respond to morally controversial clinical interventions, and doctors' notions about the norms that properly guide clinical decision-making. And we'll walk through these domains by following Dr. Stern and LC. And let me pick up the story there again. Dr. Stern refers LC to a trusted oncologist. Remember, LC's been diagnosed with pancreatic cancer. Refers LC to a trusted oncologist, but schedules biweekly appointments with herself to make sure that LC is receiving the care he needs. 2 weeks later, LC returns to her office. He looks very tired and sad. He tearfully notes he's not sleeping well and that he cannot concentrate or enjoy anything. Medical students, what's that called? The second part? Can't enjoy anything? All right. Anhedonia. Very good. Bonus points. Not even being with his grandchildren because he's anxious about what lies ahead. Now, what should Dr. Stern do in this situation? What kinds of questions might she ask? Where should she turn for help? Let's look at data on the relationship of physicians' religious characteristics to their approaches to spirituality in the clinical encounter. In a national survey of physicians of all specialties, we asked, in general, is it appropriate or inappropriate for a physician to inquire about a patient's religion and spirituality? So is it appropriate or inappropriate in general for Dr. Stern to inquire about LC's religious faith or spirituality? Overall, 55% of physicians believe it is usually or always appropriate. But that percentage varies pretty dramatically based on the religious characteristics of physicians. 72% of the physicians who are religious, that's about, by the way, in our formulation, that's about a third of U.S. physicians. About 27 or 8% would have intermediate religiosity. About 18% would consider themselves spiritual but not religious, and about 18% or 19% consider themselves neither spiritual nor religious. Among those physicians, 72% believe that this kind of inquiry is appropriate compared to those 28% among those who are neither spiritual nor religious. We asked, do you ever inquire about patients' religious and spiritual issues? 51% of physicians say yes, and that varies from 67% of the religious to 23% of those who are neither spiritual nor religious. Here's the breakdown of how people responded to inquiring by religious affiliation. As you can see, Protestants are most likely to inquire about religious and spiritual issues, followed by Catholics and those of other affiliation. Jewish doctors were somewhat less likely than their colleagues to inquire. I should say, I'll make a comment here, that this, I think, reflects from our follow-up study and from conversations with a lot of physicians, reflects something as simple as the fact that when you're in a society in which the great majority of your patients are going to be Protestants or Catholics, I think it makes sense that doctors who are themselves Protestants or Catholics, so Christians, are more comfortable asking about these things. When you as a physician are part of a religious affiliation in which you know that the great majority of your patients are not going to share that, it seems to me understandable that you're less likely to bring it up. And that's what a lot of doctors have told us. Remember that when LC returned to the office, he looked very tired and sad. He tearfully noted he's not sleeping well and he can't concentrate or enjoy even being with his grandchildren because of his anxiety about what lies ahead. Now let's look at data on the relationship of physicians' religious characteristics to their approaches to basic mental health concerns, such as how to respond to a man who is sad and perhaps depressed. So in this same national survey, we found that religious physicians are less likely to refer a patient to a psychiatrist or psychologist who presents with symptoms of depressed mood. In this case, the odds ratios are about 0.4 for physicians of high intrinsic religiosity compared to those of low, and 0.5 for Protestant physicians compared to those with no religion. Those odds are adjusted for other demographic characteristics and specialty characteristics. We also found that physicians are less likely to become, who are religious, are less likely to become psychiatrists. 47% of psychiatrists have low intrinsic religiosity compared to 36% of other physicians. And 17% of psychiatrists have no religion compared to 10% of other, no religious affiliation. So LC goes through chemotherapy. His disease progresses. He sees Dr. Stern and says, "Doctor, I do not want to languish and suffer in the final stages. If it gets to the point where I cannot tolerate living any longer, would you provide total sedation if I ask for it and keep me unconscious until I die?" Later he adds, "It's very important for me to have some autonomy and some control at the end of my life. I don't expect I'll need to use it, but would you provide me a prescription for medicines I can take to end my life peacefully if I cannot go on?" That brings up the area of morally controversial interventions. And let's look at the data on the relationship of doctors' religious characteristics to their approaches to common morally controversial interventions. We found that 25% of physicians of high intrinsic religiosity object to sedating patients to unconsciousness until death. And that was compared to 12% of those with low intrinsic religiosity. Interestingly, 43% of Hindu physicians objected to sedating dying patients to unconsciousness until death, compared to about 20% of Protestants, Catholics, and Muslims, and about 5% of Jewish and no religion. I should say we just very recently, and I need to update these with one more slide here. We've just finished analysis and publication of data which we followed up to be very specific in how we describe the sedation, to distinguish between sedation that aims at the relief of a debilitating symptom, accepting unconsciousness as an unintended side effect, which just follows the traditional norm of the rule of double effect, versus sedation which aims to make the patient unconscious until they die. And we find similar patterns. That we find that many more doctors oppose the latter, aiming at unconsciousness until death, than 25%. I think it was about 65%. And that religious doctors are more likely to oppose than those who are less religious.